Respected professor and my dear students, I take the pleasure of inviting you again for another session of our DNY RAISA online academic activities. Today we have a theory question discussion presentation. Today we have Dr. Venkatesh Rao and Dr. Sai Dikshit with us. They will discuss two theory answers. Subsequently, we'll move on with ASCII discussions, ASCII station discussions with Professor. Without wasting much of your time, I request Dr. Venkat Rao to take over. Over to Dr. Venkat Rao.
Good evening, sir.
Good evening, Dr. Rao. Go ahead.
Sir, today my topic is test for autonomic neuropathy, sir. Coming to the introduction, the autonomic nervous system, ANS, is essential for survival and responsible for the body's involuntary activities such as cardiovascular, gastrointestinal, and thermoregulatory homeostasis. Anesthesiology is the practice of autonomic medicine. The ANS is divided into two major systems, the parasympathetic nervous systems, which oversees the body maintenance function, sympathetic nervous system, which controls the flight and fight responses. Any disease state or stress during surgery can lead to changes in the ANS that can have potential deleterious effects will be there. Serious side effects will be there. The primary goal of a anesthetic management is to modulate the body's autonomic responses. Coming to the indications, the autonomic tests, the disease conditions in which these tests are performed are diabetes mellitus. This is the most common cause for autonomic neuropathy. Diabetes mellitus with prolonged duration, or in patient with poor glycemic control, or in patients with evidence of end organ damage, which includes the retinal changes or renal changes, these tests are mandatory. Second important cause is the patient with known hypothyroidism. There is increased risk of autonomic neuropathy, followed by amyloidosis. Cancer patients, usually cancer per se can lead to dysfunction, or it can be due to side effects of anti-cancerous drugs. Next is Parkinson's disease, followed by autoimmune disease like myasthenia gravis, rheumatoid arthritis, or due to toxicity due to excessive alcohol intake or vitamin B12 deficiency, especially B12 deficiency. In some cases, pregnancy can lead to autonomic neuropathy and some viral illnesses. Rare causes include familial dysautonomia, idiopathic autonomic dysfunction, Shy-Drager syndrome, some of the paraneoplastic syndrome. All are these causes where test for autonomic neuropathy should be done. But the most important cause is diabetes mellitus. Coming to the tests per se, testing of autonomic dysfunction. The first and the foremost important thing in testing the autonomic neuropathy is eliciting proper and relevant clinical history, which includes the following questionnaires. The subject or the patient should be asked the following questionnaires. Are you able to tolerate prolonged standing, or are you feeling any dizziness or syncopal attacks? Or you are able to tolerate exercise, heat, or large meal? So any problem with these conditions can lead to autonomic dysfunction. Exercise such as exercise intolerant, not able to cope up with excessive heat, etc. And the next questionnaire should be, do you sweat like other people or spit like other people? Or the other questionnaire includes, have you noticed any problem with your urination, such as incomplete evacuation of urine, or feeling of unable to feel or sense the bladder fullness? And should ask about the bowel movements, whether there is any constipation, diarrhea, or the subject feels fullness after a small volume of food. Ask history about any sexual dysfunctions, such as erectile dysfunction or any problems with ejaculation. Coming to the other important history is ask the subject regarding any medications which interferes with autonomic nervous system, especially the beta blockers. Coming to the signs, some of the important signs are resting tachycardia, which is the earliest sign in the patient with autonomic dysfunction. And these patients may have pupillary dysfunction, that is less pupillary dilatation in dark. Coming to the bedside evaluation of autonomic neuropathy. There are so many battery of tests are available. The important ones are to test the parasympathetic nervous system include heart rate variability. These tests are cardiovascular autonomic reflex tests. This include what is the heart rate response with deep breathing, heart rate variability. The principal in the heart rate increases during inspiration and decreases during expiration, which is known as respiratory sinus arrhythmia. This heart rate variability is lost in the patient with autonomic neuropathy. This is the earliest sign of autonomic neuropathy. How to perform this test? The patient can be recommended, or he can be sitting up, straight, supine, spine erect, shoulder droop, and try to reduce any pressure on the arms or back muscles. Chin can be lean forwards towards the chest. Take a few normal breaths followed by deep inhalation and count for 1 to 5, followed by deep exhalation counting 1 to 5. Ask the patient to repeat the cycle at the rate of 6 times per minute. The difference between the maximum acceleration during inspiration and maximum deceleration during expiration is normally more than 10 to 15 beats per minute. So the difference, if it is less than 10 to 15 beats per minute, it suggests autonomic neuropathy. This heart HRV can be monitored by simple palpation or with the help of pulse oximetry, or more precisely at lab with using EKG machine looking at the RR peaks. There is a ratio known as longest RR peak during expiration and the shortest RR peak during inspiration, which should normally more than 1. If it is less than 1, it indicates autonomic dysfunction. Nowadays, more sophisticated instruments are available, including software apps, mobile apps, which are readily available by used to identify the HRV conditions. Second important test is heart rate variability with response to standing. The principle involved is when a person stands from sitting position, there is fall in BP due to venous pooling, which leads to compensatory mechanism and resulting in rise of heart rate. The fall in BP is usually 10 to 20 millimeters of mercury, which is normal, and the increase in heart rate is normally 10 to 15 beats per minute. The response will be starts within 5 seconds upon standing and maximum within 15 seconds, and it comes back to normal within 1 to 2 minutes. In patients with autonomic neuropathy, due to prolonged stasis, the coming back to normal phenomena, it takes more than 5 minutes. To perform these tests, we require NIBP monitor, a multi-channel polygraphy EKG machine. Ask the patient to lie down in supine position, connect the ECG and tie BP cuff. Ask the subject to relax completely for minimum period of 10 to 15 minutes. Record the basal heart rate and BP in supine position. Then ask the patient to stand up and remain motionless for 3 minutes and lean against the wall. Then calculate the heart rate and BP. It should be normally less than 10 to 15 millimeters of mercury, and heart rate should increase. In ANS, this phenomena is not observed. There is another phenomenon known as 30:15 RR ratio. It is the ratio of longest RR interval, that is the slowest heart rate in the 30th beat in EKG machine after standing to the ratio to the shortest RR interval, that is the fastest heart rate at 50th beat after standing. If the ratio is more than 1, it is normal. If it is less than 1, it indicates abnormal. Next, third test is Valsalva ratio. The principle involved in Valsalva maneuver is forced voluntary expiration against resistance. In Valsalva maneuver, there are 4 stages. Stage 1, there is a transient rise in BP due to increase in intrathoracic pressure, followed by fall in heart rate due to activation of baroreceptor. In stage 2, there is fall in BP due to reduced venous return, and there will be compensatory increase in heart rate. In stage 3 or phase 3, the expiration stops in this phase, but there is a continuous fall in BP due to dilatation of pulmonary vessels to release intrathoracic pressure, and there will be increase in heart rate. In phase 4, consists of overshoot in BP due to the baroreceptor activation above the baseline and fall in heart rate. So these responses will not be seen in the patient with autonomic neuropathy. The procedure includes ask the patient to take deep breath followed by forced expiration against a closed mouth and nose with the help of application of nose clip procedure. Or you can use the back of the hand. So the subject has to forcefully expire against a closed glottis. In a laboratory, you can do this test by blowing to a mouthpiece attached to the sphygmomatometer against the pressure of 40 millimeters of mercury and blow at least 10 to 15 seconds and later release the strain. So the Valsalva ratio is the longest RR interval after the maneuver. That is, it should be taken at 4th stage in the EKG machine, and shortest RR interval during the maneuver, that is during the 2nd stage or beginning of the 3rd stage. If the ratio is more than 1.21, it is normal. If the ratio is less than 1.21, it's abnormal. So some of the precautions to be taken while performing this Valsalva maneuver. Be cautious in the patient with hypertension, coronary artery disease, congenital heart disease, and tympanic membrane diseases. And these results may be affected by age, sex, and medications. So changes in heart rate reflect the parasympathetic function, and changes in BP reflect sympathetic function. Coming to the test for sympathetic nervous system. So orthostatic blood pressure. So the patient complains of orthostatic hypotension if the fall in BP from supine to standing systolic is more than 20 millimeters of mercury or diastolic pressure more than 10 millimeters of mercury, it indicates abnormality in sympathetic nervous system. Second test which tests the sympathetic nervous system is cold pressure test. The principle involved is submerging the limbs in cold water around 4 degrees centigrade results in rise in systolic and diastolic pressure due to the activation of afferent pain and temperature fibers, leading to sympathetic stimulation. This is the normal response. But in the patient in autonomic neuropathy, especially sympathetic nervous system, these responses are not seen. Third test is passive hand grip test. It is an isometric test where we use a instrument called dynamometer, where we'll apply a standard hand grip against a resistance, which reflexively increases the heart rate and BP. BP is recorded in the other arm at 1 minute interval. A difference in highest diastolic BP during contraction to the average diastolic BP at rest should be more than 15 millimeters of mercury. If it is not increasing or it is less than 10 millimeters of mercury, it is abnormal. Then fourth test is pseudomotor test or thermoregulatory sweat test. In this test, the subject is placed in a chamber with temperature of 45 to 50 degrees and humidity of 35 to 50 degrees percentage for 30 minutes. Some powder is applicable which change the color like alizarin red on exposure to moisture. It is used to detect the sweat. Normal patient will change the color due to generalized perspiration. These tests are not seen in the patient with sympathetic dysfunction. Coming to the test for lacrimation, Schimmer's test. It will test the parasympathetic activity. In this test, a thin filter paper is placed between the lower eyelid and sclera, and the length of the wetting is measured at 5 minutes. In normal person, filter paper wets to an extent of 15 mm. Less than 15 mm suggests PNS insufficiency. Coming to the anesthetic implications in the patients with autonomic neuropathy. So, intraoperative cardiac liability. In these patients with autonomic neuropathy, there will be no compensatory responses such as vasoconstriction, tachycardia for compensation for anesthetic-induced vasodilatation, which can lead to life-threatening hypotension. So better to optimize the fluid status before giving anesthesia and giving a titrated doses of drugs and monitors using arterial BP, CVP for fluid management. Second important problem with this patient with autonomic neuropathy is they are more prone for hypothermia due to loss of vasoconstriction. So it should be properly taken care of. Third important thing is the patients are more prone to hypoxia induced ventilatory drive is reduced in these patients. So opioids must be given in appropriate doses. And fourth thing is there is no response with vasoactive drugs. So whatever the drugs, these patients doesn't show any responses, sympathetic stimulations. So you should be cautious while dealing with these patients. Next thing is gastric empty may be delayed. So follow the strict NPO guidelines and advise metoclopramide. Coming to regional anesthesia and autonomic dysfunction. So the presence of neuropathy should be documented prior to regional anesthesia, and these patients may have uncontrolled serious instability with neuroaxial anesthesia. So proper preoperative assessment, strict vigilance, monitoring is essential. Wherever possible, plan with ultrasound guided regional blocks than neuroaxial blockade in patient with autonomic neuropathy. So finally, the patient with autonomic neuropathy may have pros and cons with general anesthesia and regional anesthesia. So choice of anesthesia depends on the judgment and experience of the anesthesiologist. Thank you.
Very good. This question of autonomic nervous dysfunction and its implications to anesthesia has been very, very often repeated in the question, DNB examination, theory examination. So it not only carries an importance from the theory exam point of view, but also in your day-to-day practice. When you identify a patient with autonomic dysfunction, you have to be very careful in dealing with such patients because they are responsible for sudden hypotension or even death if not correctly identified and managed. And I think Dr. Venkateswara has given a very good elaborate description of how to answer this question in the examination point of view. So first thing, you first define what is autonomic nervous system dysfunction, saying that there are two subdivisions under this system of nervous system. One is parasympathetic, the other is sympathetic. There is also another third variety which is not of much clinical importance, but it is called non-adrenergic and non-cholinergic. NANC system is supposed to be the third component of autonomic nervous system, which is mainly involved with regard to the intestinal function. It doesn't have any role in the cardiovascular or thermoregulatory or other functions. So having described these two major subdivisions of the autonomic nervous system, we can just give a brief outline of what is the function of parasympathetic and the sympathetic system. And the parasympathetic, you mentioned about the sympathetic as flight or fright response, which all of us know, and parasympathetic is described as rest and digest response. So that is parasympathetic has a little upper hand in producing more deleterious effect rather than the sympathetic system loss. because sympathetic system comes into play only when you are in a stress. So having described this, then you can elaborate or enumerate all the causes where autonomic dysfunction happens, which you Dr. Rao nicely described. But of these categories of for the etiologies for ANS dysfunction, we commonly come across with patients who are suffering from severe chronic diabetes mellitus, patients who are long-standing diabetes mellitus patients. Invariably, 80 to 90% of them will develop autonomic dysfunction in some form, either a mild or moderate or severe form. And it is our duty to identify whether they are suffering from that. And that should be our main aim in evaluating a patient with especially chronic long-standing diabetes mellitus. And one more thing you can add to your answer is we nowadays come across frequently patients with Parkinson's disease also. So in those patients also this system can get affected. And the third category of patients is chronic neurological deficit patients. Other system neurology deficit patients also develop this problem. But whatever be the etiology, the majority of the involvement of the various systems, we are worried about the cardiovascular, the thermoregulatory and gastrointestinal function. If a patient with autonomic nervous system has an ejaculatory defect or erectile dysfunction, that is not going to affect our anesthesia. But we are worried about the dysfunction in three major systems, namely the cardiovascular, the temperature regulation, and the gastrointestinal system. So we should aim to identify by either the history or the test that we perform to see whether these three systems have been involved in a patient with autonomic nervous system or not. So to do that, we have to take an elaborate history. So majority of the patients with early autonomic nervous system dysfunction will complain of what is called postural hypotension and dizziness. That is the most common thing with which it starts. So if you ask them whether you get dizzy or feel have any vertigo-like symptoms when you get up from lying posture, if they say yes, that is the earliest thing that happens. And so they get trained to get used to that feeling, and then they try to adjust by not suddenly getting up. They first get up and sit in the bed itself for a few minutes, then put their legs down, and they adopt all these things. So unless we ask them the question, they may not come out with this this particular symptom that is available, present in these patients. Then the second thing is the important thing with regard to the gastrointestinal system, the feeling of satiety or fullness after eating even a small amount of meal. So that is the next important thing that you have to ask, which is very commonly experienced. Yes, I don't get, I have lost my appetite. Even if I eat a little bit, I feel full and I'm not able to eat much. And this may be causing some sort of weight loss also. The patients, the chronic diabetic patients, they suddenly start losing weight over a period of 2 to 3 months, they lose 5 kilos, 10 kilos like that, maybe because of this particular satiety feeling also. And with regard to the urination, yes, as you said, that is also very important because that may give problem in the post-operative period when they are, especially after a major laparotomy, when we don't allow them to immediately mobilize or allow them to go out to the restroom. Then this may put a problem of retention and all the added disadvantages of all these things. So you have to classify your answer into first the small description about autonomic nervous system and its function. Second, the etiologies where the autonomic nervous dysfunction can occur. Third, the important systems which are getting affected. And then fourth, you go for all the tests that you can do. And you must elaborate a lot on the Valsalva maneuver, which is can be done both clinically as well as in the lab using the raising the intrathoracic pressure by post-exhalation against the closed glottis. And it is better to describe that as phase 1, phase 2, phase 3, and phase 4 rather than stages. So use the word phase for their description and describe each and every mechanism, how those phases occur and how the overshoot does not happen as happens in a normal person in patients with diabetic, autonomic nervous dysfunction. So all these tests have been nicely described by him, and finally he has summarized nicely also the implications in that. And especially if you suspect an autonomic neuropathy and it has been established, documentation is very, very important, because after you give a regional and you land up with a sudden hypotension which is not responsive to your normal vasopressor drug and some complication happens, you will be in trouble. You may be found fault with because you have administered a regional technique in an established patient with. So the only contraindication for giving a central neuraxial, that to a subarachnoid block in a chronic diabetic patient, is the presence of autonomic neuropathy. So if that has been proved, better to skip if they come for a say lower limb procedure like ischemic limb, some debrema. The common tendency is to give a subarachnoid block and get away with that. But in patients who are having established autonomic dysfunction, better avoid central neuraxial blockade. Rather, you can go for a nerve block, peripheral nerve block, or you can go for a general anesthesia with a carefully given drug. So this point has to be remembered by all, because we do come across such cases once in a while in our practice. So this has to be borne in mind. I think otherwise all the other points have been very well given. And with regard to the thermoregulation, these patients are more prone to become hypothermic. So you know all the added disadvantages of hypothermia in a patient coming for anesthesia. So we have to take proper care of their maintaining their body's temperature, so that all the enzyme functions and other hemostatic functions are happening normally in those patients without causing the problem of bleeding or delayed recovery or wound infection and all those things. I think Dr. Rao can circulate the answer he has prepared to others by email or WhatsApp, so that all the students will benefit by that. Well done, Dr. Rao. Thank you.
Thank you.